at Trevor Mbija TV Kenya. Use the hashtag Monday Report. We'll pose your questions to Dr. Loice Ombajo, the head of Infectious Diseases Unit at the Kenyatta National Hospital, and also a lecturer at the University of Nairobi. Dr. Loice, thank you so much for making time for us. So let's just get into it. The country has just been cautiously reopened, just as the numbers continue to rise. What then should Kenyans expect going forward?
Hi, Trevor, and thanks for having me. So I think the one thing that's clear is any reopening will be associated with a spike in cases. So I think over the next few weeks to the next few months, we're going to see an ever-increasing number of cases. The cases are largely confined to Nairobi, but as people begin to move out of Nairobi into the counties, we'll begin to see a bit of a spike in the number of cases in the counties. So we just need to brace ourselves a little to handle what's coming, but also to mention that the size or magnitude of this spike will be very dependent on what we do as Kenyans. So if the reopening is followed by, public gatherings, then we'll see a larger increase. So it's very dependent on what we do. We still need to really adhere to those measures that were talked about earlier.
So even then, you talk about a spike now, and we know even as we speak, there's a backlog in testing. And based on your latest modeling, when do we expect to reach the peak and what numbers are we looking at?
So maybe I'll talk about when we expect to reach the peak and not so much on the exact numbers. So what we predicted previously is that if we continued with all the mitigation measures that were in place, so if we continued with the stay-at-home orders and, the full curfew and all the other measures that have been in place, then we probably expect a peak towards the end of the year or beginning of next year. But with the lifting of the mitigations, again, the peak depends on how much people come into contact with each other. Remember, this is a disease that's spread by how much, spread more, the more we come into contact with each other. So if there's a lot of contact between people, then we may expect a peak around September to October. And again, with less contact, the peak is sort of pushed further away. So intense contact brings the peak closer to us, but also makes it a much higher peak. If we don't have as much contact with each other, which means we are not in each other's faces, we're not in public gatherings, then we push the peak a little further, and it's not as high or as intense as it would be if it came earlier. So that's one thing. In terms of the size of the peak, the thing is, as more and more people get infected, a time will come when we may not be able to test everyone. So what's important is how many people are sick enough to require hospitalization and how many people may be sick enough to require ICU. Because again, outcomes depend on how well we can take care of the people who are sick. So for example, if you look at some of the projections of hospital needs, if we continued with all the full mitigations as they were maybe sometime in April, we'd expect that maybe by around, by the time of peak, which would be towards the end of the year, we'd probably have about 2,000 people requiring hospital in Nairobi. But with the lifting of this and more contact, then we'd expect that at the time of peak, which would come maybe towards September or October, we probably have about 5,000 people requiring hospital stay. And that number differs by county, dependent on a number of things, including the population density and such things.
So at what point then will our health systems be overrun?
Our health systems, that's a difficult question. It really depends on what capacity we have to absorb the additional cases. So, for example, if every county had enough isolation beds that they'd set aside to ensure that they can take care of the number of cases that they're expected to have, and they had enough oxygen supply for those people who require oxygen because they're sicker, and they have enough ICU space for those who may require ICU, then it may be some time before systems are overrun. But if we take an example of Nairobi, for example, just this weekend, following the very high numbers that have been announced over the last week and over the weekend, we actually had constrained in number of hospital beds and ICU beds because we only have so many that have been set aside for COVID. I think one thing to remember is that COVID has not replaced all the other illnesses. People still need hospital and ICU for heart disease or for stroke or for other infections. So you can't take the total bed capacity in a country and give it to COVID, because then people will die of other illnesses. That's why there's been this encouragement that we set aside extra beds to be able to take in COVID.
Yeah.
So once we begin to see that about 50% of the bed capacity is already occupied, then it means we need to be very worried, because we may not be able to absorb or take care of everyone who requires a bed.
Yeah, now that you brought up the issue of the ICU, what is the state of our ICU beds in the country right now? How many are available as we speak in the main public hospitals?
So I think overall, there probably may be a few hundred ICU beds in the country total. And again, I go back to the fact that these ICU beds have not just been sitting idle, waiting for COVID, They have other patients that are occupying these ICU beds, which means the capacity to take in extra COVID cases is very dependent on what's already occupying these beds. I think what many hospitals have done, including ourselves at KNH, is to set aside space that's purely dedicated to COVID patients. So if we look at a situation like Nairobi, if you look at the total ICU beds available to COVID, it would probably be just around 40 and probably not more than 50, which means if you get people who are severely ill enough to require care or ventilation in an ICU, then we cannot take too many.
So there have been concerns that even as we speak, some patients are being turned away. Are you aware of this? KNH, for example, how many more people can you take into the ICU right now?
None.
None. So the ICU beds at KNH are full?
Yes.
But are you aware that some people are being turned away in other hospitals as well?
So I guess one of the things that's happening is that maybe not all hospitals had already prepared space to take in COVID patients into the ICU. They probably have one ICU space that already has other patients, and you cannot take someone with COVID into an ICU space that is open and has other patients, because then you risk transmitting infection to the other patients.
Okay.
So in that case, you may find those patients being referred to other facilities. We've had patients referred to us in KNH. We've had patients referred to KU because they have a bigger ICU, and to the other hospitals that can take up COVID patients. So remember, taking care of a COVID patient is dependent on a number of things, especially one who's critically ill, is that you have space, you have enough oxygen, because the patients who are critically ill may require additional oxygen, and that's a big deal, because the oxygen requirements that you've noted in the patients you're managing are very, very high, which means you really need to have a stable, good oxygen supply. So that's one. The other thing is that if someone requires ventilation, then you definitely require ICU space and a ventilator. But beyond having a ventilator, we also have to have enough trained healthcare personnel in taking care of critically ill patients. So as counties are increasing their critical bed space, they also have to think about trained critical care nurses, doctors who are more conversant with taking care of critically ill patients as well.
So if you can't take any more ICU patients at KNH right now, how are you surviving? What do you do with them? Because time is of the essence. By the time somebody requires ICU and they come to KNH and you can't absorb any more, what do you do with them? Where do you refer them?
So again, the thing about managing COVID is that we really have to work together as doctors, as nurses, and as hospitals, so that the minute someone calls and that bed is occupied, there are certain things you can do. One, the patients who are there, is there any who's now stable enough and we can move out of the ICU to create space for someone else? Or can we refer to another hospital that has a critical care space? So that's sort of how we manage to, cover that situation. Many times you sort of have to make clinical decisions and say, you know what, this person came in 2 days ago, they're now stable, I can manage them in the ward on oxygen so as to create space for someone else who can't be managed in the ward. And if that's not possible, is there another hospital that can take in this patient?
Okay. So there was another report attributed to KEMRI stating that as we stand, there are more than 2.6 million Kenyans who are already infected. How true is this?
So I'm not sure I can comment on the truth of the same. I'm not one of the investigators in that study. But basically what they did was to look at blood samples from people who donated blood over the last few months. And they looked for what we call antibodies. Antibodies are things that one would produce if they have infections. So it's produced in response to an infection, which means if I test your blood, for example, Trevor, and find that you have antibodies to coronavirus, it means you've previously been exposed to coronavirus. So that's sort of what they looked at, and they looked at this in different counties, looking at samples from the blood banks to see how many people showed signs that they'd been exposed because they had positive antibodies. And they found that, a certain percentage of the blood samples that they looked at were positive. So there has to be caution always in how we interpret some of the studies. One is that the sample size may be small and not fully representative of the population in that particular county, but you also always want to be sure that when you pick antibodies, they're truly antibodies to the coronavirus and it wasn't cross-reacting with some other similar infection. So I think it's still fairly small numbers, and I'm sure they're still looking at this data. And there are many people, including Kemri, that are also looking to expand the size of this data so that it's more informative. Okay. But the main thing is that even as we look at that, we shouldn't decide, oh, well, now I was exposed, I can go do whatever I want to do. We still have to be careful because, one, you may have antibodies, but we still don't know whether those antibodies are insufficient to protect you from getting COVID again. So we still do not know how protective those antibodies will be, which means everybody still has to be careful and follow those regulations that have been put out there.
So at what point then will you advise the president to lock it down again? Which numbers are we looking at? And is there something that Tanzania knows that we don't?
I don't know what is happening in Tanzania. I've tried to ask around. I've tried to ask people I know. Clearly, I don't have very many friends in Tanzania because nobody seems to know exactly what is happening. So I think we can only use what we know. We cannot make speculations and compare ourselves to a situation which is not clear to us. So at this point, I think we call upon all partners in every country to be open so that we can learn lessons from one another. So at this point, for example, if you use Tanzania, we don't know how much testing they're doing. We don't know how many positive patients they have. We don't know how many patients they have in their hospitals, or indeed how many people have died of COVID. So I'd be reluctant to compare ourselves to Tanzania in any way.
So right now we are at 8,067, but at what point then will you advise the president to lock it down again? Because he said it himself, that if the numbers spiral out of control, we'll lock it down. But what is spiral out of control?
I think spiral out of control really depends on capacity of the health facilities to manage what is coming. So for example, if you find that in a county, you're already occupying more than 50%, maybe 60, 70% of the beds, then you need to be careful because soon you'll be overrun. And remember with COVID, death is clearly because of the virus itself, but there are people who come into hospital very sick, are treated and get well. The minute you're not able to take in people and treat them, then it means you're going to lose more people. So if you're already at a point where more than 50% of the total beds you have for COVID are occupied, then clearly you need to do things differently. Otherwise, the health system will be overrun and you will not be able to take care of the sickest people, and then you'll end up with a lot more deaths happening.
Do you have a general figure of where we are right now?
In terms of?
The occupancy. If you're saying it's more 50% towards 60, 70, that is a potential overrun. Do we know where we are at right now? Are we at 30? Are we at 20?
So that's very variable depending on the counties. Remember, counties were asked to set up to about 300 beds. And then remember, the other thing is that not all infections require hospitalization or hospital care. So some of the things that counties have to do is, one, implement a proper home-based isolation system so that those who are not too sick and have the capacity to care for themselves and isolate and properly isolate themselves at home can be taken care of at home, because that then spares the bed capacity for those who are sicker. And where home isolation is not available, maybe someone stays with elderly parents or, they share space with many people, then we consider having community isolation where someone can stay until, they're safe, they're not infectious anymore, then they can go home. So that we leave hospital beds only for those who are really sick and require care within a hospital. So having said that, I think then many of the counties are still not at that 50% because they've seen fairly small numbers. But for a county like Nairobi, we really have to take extra measures because we know that our bed capacity may be overrun fairly soon. Mombasa initially saw a lot of hospitalization, but they seem to have seen a little less in the last week or two. So I think the counties still have some reserve, but they really have to keep reporting and watching closely so that they know when it is time to sort of, heighten the measures they have to take.
But for Nairobi, are we quickly approaching the 50% bed capacity occupied?
We probably are.
Okay. So why hasn't the Ministry of Health conducted then a scientific research based on just random sampling in the counties, all the 47 of them, to get the true picture of how many people are infected rather than the targeted testing that is currently happening?
So the whole concept behind targeted testing is that you have to utilize resources wisely. So if we had no limitation in resources, we had unlimited test kits, then we probably want to test as many people as you can. We do what we call universal testing. Everyone can come in, you can test everyone wherever they are to try and get like the true prevalence of infection in the different places. But when you have a limitation of resources, then you have to be wise about how to use them. And the question is, am I testing populations that will give me the best information, and what will I do with these results that I get? So if you look at the testing strategy in the country, for example, right now, we want to test those who are sick because you're going to be admitting them into hospital, and you want to be sure that, when you isolate them, you can protect healthcare workers and you can protect other patients in that facility, and you can also appropriately manage them. The other group that you want to test is healthcare workers, because they're at high risk. We manage patients with COVID. We come across many people who may potentially have COVID. And you don't want an infected healthcare worker because they can potentially spread infection to patients. The other group that's been tested are the truck drivers. And this is because of the inter-county transport, which means if you have someone who's infected and they're going to have 50 stops across the county, then they're at high risk of transmitting infection to multiple people along their routes of travel. So in targeting this testing, we're really looking at where do I get the highest return for the investment that I put out there, and what will I do about these results that I get? So it's really just making sure we're wise about how we use the resources that we have, and that the results we get are useful to us.
But that doesn't really explain why on certain days you test 4,000, other days it's 2,000. Like today it was just about 2,000. What is the problem? How come we don't continuously test high numbers?
I think part of it has just got to do with lab capacity. And it's not just purely within the lab. It's capacity to collect samples, to transport those samples, and availability of test kits within the labs. If you note, Mondays, we always have lower results than other days, because Sunday we probably do less tests because of, people are resting. Not everybody's out there working and doing the testing. So, but part of it has just got to do with capacity to collect samples, transport these samples in a timely manner, and the availability of test kits. And the issue of test kits, I know, has been discussed many times before. Many countries around the world are struggling because this is a scarce resource, and they may not always be available all the time in the quantities that we require.
Okay, so right now we know that people will be traveling home most likely. They've been advised not to do it, but most of them will go home anyway. And we know 80% of the patients are asymptomatic, meaning they don't have any symptoms. Do we know now whether asymptomatic patients shed the virus just the same way as the ones with the symptoms, or what is the position scientifically?
So, yes, we think that asymptomatic people also shed the virus. I know recently there was some press release that sort of made people think that asymptomatic people don't shed the virus. But we think that asymptomatic people shed the virus. One, that may actually explain just how rapidly this virus has spread. But even here in Kenya, we've had situations where an entire family is infected and none of them has had symptoms. On the other hand, many times at the point of testing, someone may be asymptomatic, and we know that symptoms tend to come a few days even after the positive test. So we call it pre-symptomatic. So we may only catch someone or find somebody who's shedding the virus but they've not developed symptoms. And indeed, when we have the data that's released from testing in the community, we find that most people are asymptomatic. But by the time they get to hospital, then probably just about 50% stay truly asymptomatic. But yes, there's a lot of data now that clearly suggests to us that even someone who is asymptomatic can spread the infection. Okay. And this is an important thing to think about all the time, because as people begin to move around, you may think, oh, I'm feeling well, you know, I'm going to visit my mother, I'm going to take my children to see their grandmother, but you may very well have the virus. Then you go to the villages where maybe some of the elderly people live, and remember they're at higher risk for being symptomatic and for having severe disease. So that's why the president kept talking about taking personal responsibility. As you go, imagine if I was sick and I've gone to see my 70 or 80-year-old parents, what risk am I exposing them to?
Okay. Dr. Loice, there are several people who sent in questions via video. Let me pose some of them to you for a quick response before we wrap it up. Let's bring up the first one.
Now that some counties have not yet attained the 300-bed capacity, we are a bit worried. What is the national government doing? Will it follow up from today henceforth, or will the matter be left to the county governments to either decide to fill up to meet the 300-bed capacity, or what happens?
Okay, I'm not really sure I'm qualified to answer that question, but I guess the hope would be that county governments really take responsibility for this one, because you can't police everything seated in Nairobi, for example. You know, I wouldn't know what is happening in Turkana, what is happening in Mandera or Wajir. People really counties have to take responsibility. And as we said, if beds are filling up, I will not want to receive someone referred from another county, because the beds I have are few and they're for the people in my county. So counties really have to think about having sufficient beds, having sufficient oxygen supply, and having healthcare personnel. Those are really bare minimums for any county. Okay. But the other thing is that personal responsibility, that cannot be overstated. I think it's very sad when you see people crowding, you see pubs are full, people are not wearing their masks, so they're wearing masks on the chins. It doesn't protect us when it's worn on the chin, you know? We have to think about avoiding crowds. We have to think about protecting the more vulnerable people in our society. And maybe for the counties that are worried, now you need to start thinking, if someone has traveled from an area that has a lot of COVID, maybe I need to be a little careful. Maybe I don't need to be in a public gathering with them. It may be nice to throw them a party because you haven't seen them for 4 months, but wait a little and have the party later. Personal responsibility cannot be overstated.
All right, let's bring up another question.
Daktari, why aren't those above 58 years allowed in church, yet we are with them back in our homes? Thank you.
Okay, so when you go to church, you're not just going with your family, right?
Yes.
Even with the 100 people limit, that could very well be 30 different families, you know? And I may know what's happening within my household, but I don't know the other person who I'm going to be seated next to. We're going to be singing loudly and praising God and cheering. That's where we shed a lot of virus. So again, we're thinking of who are the most vulnerable people in the community. Remember, many people may not have symptoms, especially those who are younger, but those who are older are a little more likely to have symptoms, are a little more likely to have severe disease, especially as you go beyond the age of 60, 70, and 80. So we really have to think, how do we shelter those who are most vulnerable? And there is merit to this. You can imagine if you went to a church in my village. I have 2 villages, either in Migori or Gim, and you took 180-year-old or 58-year-old and 30-year-old, and one person was asymptomatic. And you end up with several 80-year-old people getting unwell. It means these are people who are more likely to require hospitalization, more likely to require oxygen supplementation, and may require, and may also require ICU space. So again, just think, how well do we protect them? And if we overrun what we have, where will we take care of them if they're sick? So for now, it's a tough year for everyone, but it will pass. let's make sure it passes well rather than losing a lot of people.
Okay, let's pose another question.
In case we have an increase of positive cases in the country, is our healthcare system able to accommodate more and more patients, or it will be overwhelmed? And if it will be overwhelmed, what is the possible solution? Thank you.
So I'll start with the last part of that question. The only solution is prevention. Because yes, our healthcare system is likely to get overwhelmed if we have a rising number of cases. And this is not a problem that's unique to Kenya. We've seen even the most well-developed countries get overwhelmed, yet their health capacity we thought was sufficient to absorb whatever was thrown at them. And we realized that when the numbers come in large, when sick people come in large numbers, any health system can get overwhelmed. So the only solution is to prevent overwhelming our health systems. Once it's overwhelmed, there's very little we can do, because you can't start building a hospital at the last minute. And even if you do, where will the healthcare workers come from? Where will the facilities come from? So we really have to think about not overwhelming our health system. Prevention is the only solution here.
Okay, let's bring up another question.
We have seen that we have opened, especially the hot spots, so-called hotspots in COVID-19. Some hospitals and some county hospitals have less than 40 beds. In case they surge in numbers, what are the interventions in terms of ensuring that the patients are admitted and things like that?
Is it possible that Kenyans may soon develop some immunity towards this coronavirus disease, and that they may be able to fight it and just get healed with the time? Thank you.
Yes.
Yes, so I got those two. The first one was the counties that have few beds and there's likely to be a surge.
Yeah, which you almost answered before.
Yes, let's prevent overwhelming. Let the counties prepare. And if a county knows the capacity is limited, then the burden to prevent is very high. That's when we're thinking we must be sure that people wear their masks, that there are no public gatherings, that pubs are not open late into the night, because it's very hard to maintain social distance in a bar at 11 in the night. So there are certain things that we'll have to really think about in terms of prevention.
Okay.
The second question was around immunity. So the simple answer is we don't know yet. It's probably to be expected that like we've seen with many viral infections, is that there may be some level of immunity, but we don't know yet. Very recently, there was one paper published from Spain. Spain had a lot of cases and a very high mortality as well. And they went looking for, the presence of antibodies. We talked about antibodies earlier in the population. And they found that the prevalence of having antibodies was actually quite low, which means they may not have that much immunity, though immunity is not just from antibodies. There may be cells that may protect us. But the truth is we still don't know. We expect that, yes, once a significant population has gotten infected, there may be what has been called herd immunity, which means that population is less susceptible to developing disease. But how long this immunity lasts is still something that we are not very sure about.
Okay. Let's bring up one final question.
The idea that it's now personal responsibility of every Kenyan to ensure that they are safe and that their health is priority. I think that is the way to go, because personally, if it were to prolong, our economy would suffer and we will not be able to stand in the next couple of months or years.
All right. That is not a question per se, but it's just agreeing with the issue of personal responsibility. But Patrick Chiriba here, Dr. Loice, before I let you go, is wondering, can someone contract the virus and recover without knowing it?
Yes. If someone is asymptomatic, then they may never know they're ill. And that's why that issue of responsibility is so important. It's responsibility to protect myself, but also to protect others, because I may have the virus, shed virus, and spread it to other people, and I have no control over how the other people will respond to this virus. They could get very sick, they could die. So it's protecting myself, but also protecting other people as well.
All right. Dr. Loice Ombajo, thank you so much for speaking to us this evening. I'm sure we'll have this conversation again as time goes by. We'll review and we'll hopefully invite you again to give us the heads and tails of what's happening in the country. That's Dr. Loice Ombajo, Head of Infectious Diseases Unit at KNH, and also a lecturer at the University of Nairobi. We're taking a quick break here on the Monday Report Town Hall session. When we come back, we're now speaking to Simon Kimutai. He's the chairperson, Matatu Owners Association. What we know so far is that people are gearing up to travel one way or another. Will the Matatus hike their fares? Will they remodel the Matatus from 14-seaters to 8-seaters? Because all Matatus now have to take 60% capacity. What is the way forward? We'll find out from the chairperson of the Matatu Owners Association next.